I'm Dr. Daniel Griffin.
Hi, I'm Dixon DePalmier.
Welcome to Chapter 3, Urinary Tract Infections.
Whoa.
So this, I must say, I find a very interesting topic.
I do too, actually. I think there are lots of new revelations about the human microbiome that relate very much to this topic.
Yes. Urinary tract infections, as we were talking with some of the Howdy Partners people who've helped us produce these videos, is that this has become a more challenging topic for clinicians throughout the world. The first thing, I think, which is a critical point, is the patients who come in with urinary discomfort is number one, not all reports of urinary discomfort are urinary tract infections.
That's also very interesting.
So that's number one. Very concentrated urine, perhaps in a dehydrated individual, can cause discomfort and be quite irritating. You can have inflammation or urethritis due to sexually transmitted pathogens. So when we're trying to make this...
Or trauma.
Or trauma.
Sorry, interrupt. But
no,
trauma.
I think you can have trauma, you can have discomfort or dryness in that area that's being viewed or perceived as...
Exactly.
So,
referred pain.
So I think one of the important things is you're going to need, and we're going to bring this up in several lectures, sometimes you're actually going to need a little bit of technology when possible to help you, or you may end up over-treating. So one of the things we'll come back to is urine test strips, which are very inexpensive, relatively. I would say significantly less costly than over-treatment with antibiotics of people who don't have urinary tract infections.
Right.
So I think I'm going to also throw that as sort of our introduction primary pearls, is that one of the really critical bits of technology to try to have in these settings and make use of is the urine dipstick test.
Which sounds easy to carry with you no matter where you are.
They really are. And one of the nice things is they don't require a machine.
Right.
Most of the urine dipstick strips have a canister, and there's an interpretation on the canister. It even tells you how long to wait before you read them.
Right.
It gets dipped in the urine, and then you wait a certain amount of time, and you're looking for colors, and your colors are telling you different things.
Sure.
It might be telling you about the pH of the urine. It might be telling you how concentrated the urine, which is going to be helpful. Concentrated urine, as mentioned, is irritating in and of itself. It might tell you whether or not there are activated white cells, something called leukoesterase. Might tell you about nitrites, which are produced by bacteria. So it might tell you about blood. Might detect blood in the urine, which might suggest something else. Right?
Exactly.
What can you think of as a parasitologist?
I believe I could come up with at least one. Schistosoma hematobium is the first thing that pops into my mind, but I'm sure that's what you were prompting.
That's where I was
me to
prompting.
say.
I was prompting with that.
Right. Also, I think there was an era of education where we were taught the 7 sterile fluids of the body. And that is obviously no longer the case. I mean, we used to memorize each of those areas like cerebrospinal fluid and blood, urine, lymph, cochlear fluid in the inner ear, the region of aqueous.
The vitreous.
Vitreous and aqueous humor, all of those areas. And that's all going out the window now that we've learned how to detect organisms that you can't culture. They're everywhere, basically. We are a living zoo of microbial life, which serves the purpose of keeping us healthy. So sometimes things get out of control. And basically, that's what you're going to tell us.
Well, I think that's critical in our understanding, is that it's very easy to overtreat people who come in with urinary discomfort and say, and I think clinicians, there's almost an enjoyment because you're like, now I know what it is.
Exactly.
Now I know what to do.
Exactly.
But that doesn't help if what you think you're doing is wrong.
Correct.
I will say one is a large number of people with urinary discomfort, if they increase fluids, even if there was an increased bacterial load, most people will get better. The human race did not go away in the prebiotic era. We survived up until then without antibiotics.
That's right.
women get more urinary tract infections than men, and the women did not all die off. They increased their fluids. They often resolved without antibiotics. I think that's really helpful because that brings up a really important distinction that I want to raise, is the distinction between a simple urinary tract infection, so simple cystitis, versus, I'll say, a more serious, a systemic urinary tract infection, pyelonephritis, an infection associated with fever, elevated white blood cell count, if you have the ability to do a complete blood count, pain in the flanks, in the areas where the kidneys are, because those are not going to resolve, and those can lead to a person becoming quite ill, and about 1 in 5 people will end up with the bacteria actually getting into the blood. So these can be quite serious infections, and the distinction of looking for those concerning warning signs is really important early on. When someone says, I have this discomfort, pretty quickly is, are you having fevers? Are you having chills? Are you having low back pain? How do you feel? Do you feel sick? A simple urinary tract infection is discomfort, but usually not feeling sick, usually not having, well, I should say it would be not having systemic signs and symptoms.
And besides that, as you mentioned before, you've got male and female construction differences in anatomy that could be related to prostate, and not urinary tract necessarily,
and that
originated in the urinary tract but moved to another place.
That could be a huge challenge. Not only is it a challenge in the diagnosis, but it's a different therapy. If you treat someone for just a week or two, and they have infection in the prostate, you're going to get a lot of failures. You're going to get a lot of people who come back and require more prolonged therapy. So I think this is part of why I like urinary tract infections so much, because there is a complexity here. There is a challenge to getting it right. So when we get to the diagnosis, we've talked a little bit about distinguishing your clinical symptoms, cystitis versus an upper or pyelonephritis. But when we get to the diagnosis, we get back to the same thing. The urinary discomfort alone with a negative dipstick, that is not a urinary tract infection. And you really don't want to treat those people. You want to withhold those life-saving antibiotics, as we say. Because what we're seeing in a lot of parts of the world is by overuse, we now run into issues where so many of the bacteria are resistant to our antibiotics. So you want a consistent clinical scenario, and then you want at least a minimum amount of laboratory confirmation. So it's going to be pretty hard, I think, to approach people with potential urinary tract infections if you don't have at least the ability to do a urine dipstick.
So are there groups of people that develop urinary tract infections more chronically than other groups, like people who work in the field you were mentioning, people who do a lot of physical labor, who don't drink a lot, who are also forced to get rid of their waste products, both solid and liquids, in the natural world, so to speak, and maybe run into some contamination problems with their hands as well because the lack of sanitation is there?
So yes, the people who are at highest risk for urinary tract infections, one is females versus males, more urinary tract infections in females. Certain individuals have a higher incidence. There might be certain women who 3 times a year have a urinary tract infection.
3 times a year? 3 times a year,
and that might be normal for them.
Wow.
There's a certain rate at which physicians, clinicians might intervene when it becomes recurrent urinary tract infections. Hydration is a huge impact has a huge impact on who gets urinary tract infections. People who drink less, not only are they at risk at kidney stones, but they're also at more risk of urinary tract infections. Hygiene is an issue, and this becomes more of an issue in, let's say, the elderly or people who have cognitive impairment. There may be an issue cleaning themselves, where they may be wiping in the wrong direction, because a lot of the urinary tract pathogens are originally coming from the feces. So if you're not cleaning yourself, if you're not cleaning your hands, if you're not wiping or cleaning properly, it's too short a distance, unfortunately, between where the feces comes out,
Understood.
where the urine comes out, And particularly in a woman, it's a very short distance between the outside world and the inside of the bladder where the infections can...
Yeah, that's a lot to think about.
So I want to go back, actually, to something you brought up about our sterile fluids.
Right.
And I think this is something that complicates urinary tract infections and is a reason for over-treatment. And we've coined terminology, which I think, once we have a name for something, I feel like it's the fantasy novels. Now we know what to do because we've named it.
Right.
But they've created the terminology of asymptomatic bacteriuria. And this is the reality that, like you brought up, Dixon, urine is not sterile.
Nope.
There's always bacteria
Yep.
and other pathogens in there. There's always microorganisms in there. But there's a threshold at which we move from tolerating it to it being benign colonization, asymptomatic bacteria, and then moving into an actual infection.
Yes.
We used to think that was a line in the sand. We used to use greater than 100,000.
Unfortunately, the wave came in and washed that one away.
It did. I know, that's the great thing about lines in the sand.
It's gone. It's totally gone.
And that's a good thing I think about teaching is lines in the sand are not.
That's right. I can often remember hearing the term clean catch when they advised women on how to bring a urine sample in to make sure it's not something else. And a clean catch, there's no such thing as a clean catch, basically.
It's like safer sex. It's cleaner catch. You're not going to do it without cleaner.
That's right.
And so we used to think we could use the bacterial count to determine whether there was an infection or not. We realized that's no longer true, and that's the great thing about the asymptomatic bacteria. You can have greater than 100,000 colony-forming units per milliliter, so colony-forming units per milliliter, and the person can be completely asymptomatic.
Wow.
And treatment does nothing helpful.
Wow.
It does harmful things, the risk of antibiotic issues, the risk of resistance.
It alters the normal microbiome and
throws
opens
off
the door for lots of visitors that we don't want.
Exactly, exactly. So that's important that we're not treating asymptomatic bacteria. It's important that we're actually treating people when they have urinary tract infections and not just giving them antibiotics to treat discomfort, which could be due to many other things. So let's talk about treatment. So let's say we dot all our I's. So they've got the urinary discomfort, they've got a positive dipstick.
Yep.
After a while, particularly I'll say women who often have a lot they'll know after a while, and a lot of times clinicians will treat them because what they say is a reliable clinical picture. When possible, try to confirm. You really don't want to fall into that, oh, but we're going into a holiday weekend, right? Or clinic, we have the holiday season is upon us, and so the clinic will be closed for the next 3 days. You really want to try to avoid overtreatment. As mentioned, many of these will get better on their own.
It's true.
Something most people don't have, but when you have it is fantastic, is the ability to actually get a urine culture, to actually know what specific bacteria is causing the urinary tract infection. And when you're looking at limited resources, if that's a resource level you can get up to, you can get urinary cultures, that can be super helpful, not just for the individual, but for the area because of the increasing resistance rates. In the United States, ciprofloxacin, which was a very common cornerstone in the New York area, I would say a third to almost half of the common urinary isolates are resistant, so that is no longer very helpful. In many parts of sub-Saharan Africa, there's been enough of the sulfur drug use that many of the common urinary pathogens are resistant to the sulfur medications.
Wow.
So when you can, either on your individual, on your population, or if you can get data from the health ministry, it really guides your choices of antibiotics should you want to use them for the individual to treat.
Where would you find that information?
So in many places, the hospitals keep track.
Okay.
In many countries, the government will keep a list. The health ministries will often have guidelines on which antibiotics they recommend based upon regional resistance patterns. So there's a lot of information, again, making treating what seems so simple, a simple urinary tract infection, much more complicated.
Right. Is there a network of physicians that keeps updating the information, and maybe you can go to that network?
Whenever you're thinking about either practicing in your area or you're going to a new area, you want to look at the ministry guidelines if you can.
Sure.
World Health Organization has great guidelines.
They're up to date.
We have some, what I'll call is basic recommendations that are starter points that those of you who are watching will see now come up. But those of you who are listening, you can look in our book. But I'll say a couple of the things that have come up is we've started using more amoxicillin. Going back to that, higher dose amoxicillin is still quite effective because we can get high enough doses to help push people towards cure. For a simple cystitis, we're usually only treating for about 3 days. We're moving away from ciprofloxacin and the sulfameds in a lot of parts of the world. But again, I think this reminds me of a lecture we did on pain. There's going to be a certain number of individuals that have more serious infections.
Sure.
Pyelonephritis.
Sure, of course.
They may have fever, they may have vomiting, they may be beyond what can be treated in just a simple 3 days oral. And for some of these people, we'll actually recommend either ciprofloxacin or an intramuscular or intravenous ceftriaxone or some of the other medicines that we list.
Got it.
And in those cases, you're going to treat a bit longer. And the duration is going to depend upon the choice of agent.
Right.
Ciprofloxacin might be 5 days of twice a day, where your ceftriaxone or some of your cephalosporins, you may treat for 10 to 14 days. But again, I think as we always try to bring up, if the person is too ill, if they're beyond the resources of your clinic, know your regional referral options.
That's right.
And if it's something more complex, your favorite complication of urinary tract infections is prostatitis. Again, that's not a simple urinary tract infection. That's going to require a longer treatment course and a selection of antibiotics that better penetrate the prostate.
Personal experience. Guilty as charged. And you have to be perseverant. You can't abandon the therapy just because you start to feel better or the symptoms abate or the signs abate. You have to follow the instructions to the letter in order to make sure that works. And I think it's very difficult when you're dealing with indigenous situations where it's rural medicine, it's in a foreign country to begin with. We have limited resources. These are very challenging issues to deal with, I think.
No, and I'm glad you will finish on that note, but it used to be in infectious disease that we had different durations. We used to treat pneumonia for 3 weeks. We now know that's much too long. But the durations, particularly for urinary tract infections, these are well studied.
Okay.
And so if you want to get a higher than 90% cure rate, if you want to get better, you want to take the full duration of treatment that's recommended.
You bet.
If you stop when you're starting to feel better, not only might the infection come back, but you're setting up a scenario for resistance and failure of that antibiotic to work in the future.
Those are complicated issues that require good conversations between doctors and patients. And healthcare givers of all kinds also. Great.
All right.
Good.
Well, thank you for joining us again for
Indeed.
another talk.
Yep. We'll be back.